Welcome back, everybody. My next guest is a Harvard-trained physician and one of the top eye surgeons in New York City. His practice, Mandel Vision, is in the process of reopening. Doctor, welcome to the Chris Salcedo Show.
Pleasure to be here.
How effective are the lockdowns in your estimation? What can we learn from Japan and Sweden, nations that didn't lock down and are seeing similar or better outcomes than the United States?
So this is not, I think what we're dealing with is a false dichotomy between your life or your livelihood. I think what we need to do is balance this better, explain this better, and be able to tell people we're going to protect people as much as possible. We need to get people back to work. Until we have a vaccine, the virus will still be out there. Our goal, and this is, I don't think, emphasized enough, is to get an infection rate under 1, which means that one infected person does not affect more people, so that it actually is decreasing, and we don't overwhelm the system. But as long as there's the virus out there and we don't have a vaccine, that we don't have something called herd immunity, it's going to be out there. So we need to manage expectations. And if we can get over our fear and we do the right things, social distancing, hand washing, masks, we can manage this and we can get back and can wait for the vaccine. But that could be 6, 12, 18 months or more.
Right. And what about therapeutics? Because I have heard it said out there that the reason why hydroxychloroquine, a 50-year-old malaria drug, and zithromycin and zinc, the reason why they're being poo-pooed by some in the medical community is that they're not profitable. And remdesivir is brand spanking new, and it's really expensive. And cloning antibodies, oh, that's really new and really expensive, so that there's a money component behind this. Are you buying any of that?
I really am not. I mean, let's break this down medication-wise. We have things that go directly against viruses, antibodies, convalescent plasma. People who are infected use their antibodies. We can make monoclonal antibodies, man-made, like Regeneron. We can do antivirals, and that means to stop their replication, stop them affecting cells. Then we have to deal with their consequences, the immune system. So the latest hot topic is interferon, which could boost the immune system. But we're hearing about that this virus causes too much immune reaction, so we have things that are that like fight autoimmune diseases to decrease inflammation. Then we have the medications to affect the consequences. So they create clots. We have blood thinners. If we have damaged lungs, they're talking about stem cells that they aerosolize that you could breathe in to make more cells. So you got to remember, what are medications for? They are a bridge until we get a vaccine, until we get herd immunity. And that's how we will conquer this in steps.
Yeah, Johnson & Johnson out over the weekend saying they will have a vaccine by year's end. Are you confident in that?
Okay, so let's talk about vaccines. What is vaccine supposed to do? They're supposed to increase your immune response to the virus, to do it with a strong response and be safe. The first ones are probably going to be the one from Oxford in England, because that one has been around for a while, but they may not be able to, even if it's effective, ramp it up to the biggest numbers. 2 other ones go by something called messenger RNA, where they give you something for you to make some of the spike proteins in a benign form, and then you form your own antibodies. That's done by Moderna and Pfizer. It's never been done, but if it can be effective, they can ramp that up into the billions. We'll have to see. There's over 100 vaccine trials going on right now, and maybe if we're lucky, and we can have some sometime next October, November, December, but probably only for vulnerable people.
Now, the mindless press is out there caterwauling about testing, and they never distinguish what kind of testing are we talking about. What type of testing is valuable in stopping the spread of the virus?
Okay, so we have 2 types of tests. We have PCR tests, and that's the test that, except for the Abbott test, really could take 5 to 7 days for them to process. And the latest thing are what's called antigen tests. Antigen tests, what they work on is finding a piece of the protein. And that you could do by some saliva. They're not as sensitive, not as accurate, but they could be done for large screenings. If we can get the antigen tests up, we can get them into screenings. This is for active virus, because what do we want to do with active virus? We want to get those people, isolate them, do contact tracing to minimize, to keep that infection rate under 1. So that's one set of tests. The other types of tests are antibody tests. Antibody tests, the best, these are done by blood. If you do them by serology, we're trying to see if you have enough antibody to be immune. We don't know what that means yet. That somebody who had a asymptomatic case create enough immunity? Can you be immune and still pass it on or catch it? Those are open questions, but I think you'd feel a lot better if you have had the virus and have antibodies to feel that you're probably not going to get it again. Gets to the vaccine part. If we get people to have a reaction to this, will we have to give them boosters every year? That should be the least of our problems. We need to get to a point where we get this herd immunity up. Measles, it's about 95%. For COVID, it's maybe 70, 75% of our population. Not as contagious, but still a huge number.
Yeah, and the antibody test would be a great boost to getting folks back to work. Nursing homes, there's been a lot of focus, in particular in New York, on nursing homes, but also around the country as well in certain communities. Did we fail them?
Listen, in retrospect, people always like to point fingers, especially this has become a political argument. Nursing homes are unfortunately the places where you have the most vulnerable people. They're elderly, they're sick, they're in close quarters. Yes, in retrospect, we do better, but you see over the years other types of infectious diseases spreading in there. So what we have to learn from this is going forward to learn how to protect our most vulnerable citizens. That's what makes us special, is we care most about the most vulnerable. But I don't using these things that we failed them or that we didn't fail anybody. People did their best, but we need to do better.
Now, you're an eye doc, and I've been wanting to ask this question for a while. What is more of an access point for transmission? Not wearing a mask, the mouth, or the eyes? Because my understanding is, maybe you can correct me if I'm wrong, but you touch something, you've got the virus on you, you start rubbing your eyes, and that's it.
Right. So we do know that portals of entry, I think still the biggest one is going to be respiratory, people who cough and sneeze, and that's why we want to wear a mask, get rid of those big droplets. But we've also learned that there is something in the tear film that could help the virus get into your body. So people talk about not just wearing a mask, but to wear a shield. When I'm seeing patients, that is what I do. I have not only an N95 mask, but I have a shield to protect any spray that could come off. And those obviously can be alcoholed off. The nice part here is that this virus is usually killed by isopropyl alcohol, whereas an adenovirus, a cold virus, usually isn't. So the eyes are there, but I still think this is mainly a respiratory situation. And again, what's the best way to stop this? Be 6 feet away or more from somebody else and have the protection on.
Dr. Eric Mandel, very informative, sir. Thank you very much for being a guest here. We'll have you back on soon. Still to come, folks, Atlanta's mayor is blaming President Trump in that shooting death of a black jogger in Georgia. Can you believe that? Is that fair? It's Chris Salcedo Show here on NewsMax TV.